announcements. Hello, everyone, and welcome to the Parkinson's Foundation Education Program, Women in PD, Closing the Gender Gap. I'm Nancy Neal, and I'm a Community Program Manager for the New York, New Jersey Parkinson's Foundation chapter. Thrilled to be with you here today. And joining me from behind the scenes, you already heard from Danielle, and we also have Melody, and we're tuned in from various parts in the Northeast. I'm logged in from Rochester, New York. Would love to know where you're logged in from. If you want, I encourage you to take a moment and write into the Q&A box where you're logged in from. And I'll check back throughout to see where folks are from. But we really want to warmly welcome you and join you, and thank you for joining us in this education program. In addition to the local program that we're about to do today, the Parkinson's Foundation also holds weekly programs referred to as PD Health at Home. And these happen on Monday, Wednesdays, and Fridays. To learn more, go to parkinson.org/PD Health, and you'll see that there's a huge variety of programs of interest. One of the things that makes our work possible is the great support that we have from our corporate partners and sponsors. So I'd like to recognize our wonderful supporters today who happen to make this program possible. It's my honor to say a big thank you to 3 supporters, first being AbbVie. Many thanks to everyone at AbbVie for supporting our mission. The next big shout out is to our friends at Acadia. We do so appreciate all of your support, your generosity. And lastly, but not least, to our friends at Medtronic. Thank you so much to all of our supporters. And one of the things that you can do as viewers is that you can go to our chapter page, parkinson.org/NYNJ, chapter/supporters, and you'll be able to check out all of the great work that the people at AbbVie, Acadia, and Medtronic are doing in the world of neuroscience. Simply visit our website and you will be able to find all the information about what they are doing, what they're up to. I'd now like just to take a moment to fill you in on what the Parkinson's Foundation is all about and what we do. To achieve our mission, we pursue 3 main things, 3 goals: ensuring better care for everyone today, understanding Parkinson's through research tomorrow, educating and empowering the Parkinson's community like we're doing today for all of us. And we do all of this by building on the real power of the collective global Parkinson's community. So thank you for being part of this today. That means you're part of that community. For today, the foundation has a wide variety of free resources that you can access. Numerous books, fact sheets, education events like today, podcasts, and our Aware and Care Kit, which is a hospitalization kit for when someone with Parkinson's has to go to the hospital. In addition, our helpline is staffed by remarkable specialists in Parkinson's. They are so happy to hear from you. Please reach out to them with any of your questions. The number is 1-800-473-4636. And I'm also very excited to tell you about a really special research initiative that the Parkinson's Foundation has started. PD Generation is the first of its kind national initiative that offers free genetic testing to clinically relevant PD-related genes and free genetic counseling to help participants better understand the results. I encourage all of you to visit, once again, our website, but this time you can go to parkinson.org/PDG. And a way in which you can get more involved and help support all that we do, whether it's our research or advocacy, education, is by participating in Moving Day. And you'll notice that I included the Central New York Moving Day date, April 25th. But this is what helps drive all that we do. So go to movingdaywalk.org and learn how you can participate. We would love to have you as part of Moving Day. So now I'll ask Dr. Durfy to get ready and share her screen. And while she's doing that and getting ready, I'm very excited to be able to introduce and welcome our guest speaker today. Dr. Jennifer Durfy is an associate professor of neurology at Albany Medical Center. She specializes in movement disorders and treats individuals diagnosed with Parkinson's, atypical Parkinsonian disorders, essential tremor, dystonia, tics, and Huntington's disease. She has been the principal investigator in several pharmaceutical and device trials, sub-investigator in numerous others, and acts as the Albany Medical Center's Movement Disorder Fellowship Director. She has a special interest in deep brain stimulation for treatment of PD and other movement disorders. Dr. Durfy, thank you so much for being with us, for doing this presentation. I'd now like to hand it over to you to get started.
Thank you, Nancy. Can everybody hear me and can everybody see me?
We can hear you, Dr. Durfy. We're having trouble seeing you, though.
Okay, I thought that might be the case. Hold on one second. Okay, now you can see me.
Yep, it looks perfect. Thank you. Then you can switch over to your slides now.
Great. Well, thank you all for being here. I really wish it was different times and that I was talking to everybody in person. It's always nice to have an audience when you're giving a talk, but that's okay. I appreciate that everybody's shown up. I am so happy to be able to talk for the Parkinson's Foundation on this topic, and I so appreciate that the Parkinson's Foundation has decided to make this one of their focus topics, because I think we all know that diseases are different and handled differently and present differently and require different treatment in women than they do in men. And so we'll get into all of that and why that's all important. So today we will be providing an understanding of how women have been underrepresented in Parkinson's research and in the development of Parkinson's treatments. We'll learn about risk factors for developing Parkinson's and if they're different in women than they are in men. We'll understand how Parkinson's symptoms might be different in women than men, and provide information on treatment and care strategies that are specific to the needs of women. So it's not a secret, men and women are different. You know, it used to be that in research projects, they used only men with the assumption that any finding that we had in men would just automatically apply to women. And we now know that that's just really not always the case. So these are some of the things we're going to talk about. I'm going to jump over this slide and head on to the next one. So this is sort of a timeline of how women finally became important or seen as important in scientific research. So it used to be in the 1970s and earlier that women of childbearing age were excluded from any type of clinical research. In 1986, there was sort of a suggestion from the National Institute of Health that they should start maybe including women in some of their research projects. Then in the 1990s, it finally became much more accepted and much more necessary for women to become involved. So in 1993, women of childbearing age started to be included in studies. And that women and members of minorities and their subpopulations were also included in all research projects. And it wasn't then until 2012 that it was made mandatory that when a research project or when a research study is reported, it's also, the results are also then broken down into different genders, race, and ethnicity, so that we can sort of see the differences in how different people respond. Okay, and why is this important? So the thought in the past that any finding that they had in a man would apply to women has now been proven wrong. And these are just a couple of many examples. So for instance, Ambien or Zolpidem is a very commonly used sleeping medication. Some of you may have been on it or are on it. And for many years, there was no dosing difference recommendations for men or for women. And so in 2013, another study was done which showed that there is some continued levels of Ambien in the blood in the morning in men and women, but in women at the same dose of men, it was high enough that it would impair their driving. So the label changed so that the maximum daily dose for women is different now than it is for men. In 2014, it was recognized that there are unique risk factors for stroke in women versus in men. And I won't get all into that because it's very scientific stuff, but just a couple of examples on how things are different between women and men in treatment and in diseases. So having this gender-specific data is really useful because it allows us, so in treating Parkinson's, all of you who have Parkinson's know that it's a really individual disease, and the treatment that you're getting is going to maybe be vastly different than the treatment that your friend's getting, because you have different issues and you have different things that need to be addressed. So having even more information about how that might be different depending on your gender will help us to even better tailor your care. Okay, so we're going to talk about how the risk generally of getting Parkinson's disease and how that might be different in men than women. Okay, so 1 million Americans live with Parkinson's disease. The last I checked, I think there are about 328 million people in the US. So that would be maybe 1 in 328 people, if I'm doing my math correctly. So this is what we refer to as prevalence. So prevalence is the number of cases of a certain disease in the entire population, or in a specific population. And then the incidence, so the number of new cases per year, is about 60,000 in Americans. It's well known that there seems to be a lower rate of Parkinson's disease in women than in men. So it's about a 3-to-2 ratio men to women. We don't really know exactly why that is yet. We'll get into some ideas later on. And you can see that across the board in all ethnicities, all races, men have a higher rate of diagnosis at about 2/3 proportion. So why is it that women have a lower risk? And why is it important that we figure these kinds of things out? Women live longer than men. They're going to encounter different obstacles throughout the course of their journey. It's important to understand those obstacles in order to better treat each individual. Okay, so here is a poll. There's going to be a question that pops up, and we encourage you all to get on your computer and answer it. There should be a question that comes up. Danielle?
Yep, the question is up on everyone's screen. I will just give folks a few more seconds. We have about 40%, so let's hope to get a few more people to fill it out. Okay, so it looks like a majority of folks chose, so the question is, do you experience non-motor symptoms? And most people selected yes, but my motor symptoms are more bothersome. And then the second highest choice was no. So some people do not experience any non-motor symptoms.
Okay. So we'll talk about motor and non-motor symptoms in a little bit. So what's a Parkinson's risk factor? So a risk factor is a factor that increases your risk of having sort of another situation arise. So things that increase your risk factor of Parkinson's disease would be things that make it more likely for you to develop Parkinson's disease. This is different than an association. So there are some things that are associated with a higher risk of Parkinson's disease, but aren't necessarily a cause of Parkinson's disease. For example, just this graph on here, you know, it's in the summer, people eat more ice cream and there are more violent crimes. Does this mean that the increased ingestion of ice cream is leading to violent crimes? No, it doesn't mean that. It just means that they both happen to peak in the summer months. So some risk factors for Parkinson's disease. Age is the largest risk factor for developing Parkinson's, and that's obvious. You know, a 60-year-old is much more likely to develop Parkinson's than a 20-year-old. Being male in gender is a higher risk factor for developing Parkinson's disease. Genetics. So this is a question that I get a lot, especially in people early on in their disease. So do genetics play a role? So having a first-degree relative with Parkinson's disease does increase a person's risk of developing the disease, but only about 10% of all cases result in a direct genetic defect. And so I'm going to take a minute to explain how these genes are inherited. The most common way that a familial Parkinson's disease gene is inherited is by what we call a dominant method. So we all know that our DNA has 2 copies. One of those copies comes from our mother, one comes from our father. And so every gene also has 2 copies, one from our mother, one from our father. An autosomal dominant gene is one where you only need 1 copy and that trait is going to be expressed. So for example, the brown-eyed gene is autosomal dominant. So and the blue-eyed gene is not. So if I inherit a blue-eyed gene from my dad and a brown-eyed gene from my mom, that brown-eyed gene is the dominant one and it's going to be expressed. So in that situation, you're going to see Parkinson's disease. If we're talking about Parkinson's disease, it's going to happen in every single generation. This is the most common way for this to be inherited. There's also autosomal recessive, where you require 2 copies of the same gene, like 2 copies of the blue-eyed gene, in order to express blue eyes. So there are some genes identified in Parkinson's disease that in which that's the mode of inheritance. And then we haven't identified a lot, but there are definitely some genes that are called risk factor modifier genes. So you might inherit this gene. It's going to give you a predisposition or an increased risk of developing Parkinson's, but it doesn't guarantee you're going to get it. And so, you know, one of the questions we have is, so what is it that triggers that gene then to be expressed and to cause you to have Parkinson's? Some of the environmental risk factors that we know include pesticides. And when I say pesticides, I mean farmers who work out in the fields and pesticides, or you know, people who work in greenhouses with pesticides, not sort of the pesticide that you get on your apple in the grocery store. Heavy metals, particularly manganese, which really is only an exposure for people who weld. And then several other environmental factors, and then traumatic brain injury. And again, with this, we're talking people who participate in activities in which they have repeated traumatic brain injuries, not normally sort of 1 concussion. So in most cases, Parkinson's disease is due to a combination of genetic and environmental exposures. So you maybe have inherited this gene that increases your risk, and then there's some type of environmental trigger that we may or may not have identified, and you end up with Parkinson's disease. Is there anything that protects against Parkinson's disease? So physical activity, if you've seen me as a patient ever, you'll know that I see this as a more important aspect of treatment than any of the medications I give you. It's really the one thing that changes outcomes in Parkinson's. It's better than any of the meds that we use. Exposure to tobacco. So I don't think any of us are willing to say that if you smoke, you're not going to get Parkinson's. But it does seem that people who smoke have a lower rate of developing Parkinson's, or maybe it's people who don't smoke are more likely to develop Parkinson's. We're not really sure why that association exists. Coffee and tea drinking. People who drink lots of coffee and tea tend to have a lower rate of developing Parkinson's disease. This is true of men and women, but this decreased risk seems to be stronger in men. Certain diets and nutrition habits, and there's a lot of controversy surrounding that, so I'm going to not get too much into that. And the use of some medications, so it seems like in men, the regular use of anti-inflammatory medications like ibuprofen, that group of medications seems to correlate to a lower risk. And then higher levels of urate. So urate is something seen in people with certain types of kidney stones. It's a chemical that sort of contributes to the development of kidney stones. So it says that there's a phase 3 trial looking at this now. That trial is completed. It was completed last year, and it was ended early for lack of benefit. So I think that higher level of urate question is questionable now. And what about estrogen? So the most obvious difference between men and women, sort of chemical-wise, would be the estrogen. We haven't really found any link between increased estrogen and a decreased risk of Parkinson's. If there were, we would assume that after menopause, when estrogen levels decrease, that the rate of Parkinson's in women would start to match the rate of Parkinson's in men. And it just hasn't been shown to be the case. And then further, women who have Parkinson's disease and are pregnant, when estrogen levels are really at their highest, don't seem to have any improvement in their symptoms, and actually their symptoms seem to be worse. So why is there a lower risk in women? So maybe there are some biological factors, and there probably are, but the environmental factors, if you kind of review the ones that we talked about, women are less likely to be exposed to pesticides. They're less likely to be working in the fields, in the greenhouses with heavy pesticides. They're less likely to be welding. Not to say that women don't do these things, but it's just more common for men too. And they're less likely to participate in activities causing sustained head injury. And those would be things like football and boxing, those kinds of things. So we don't really know is the bottom line, but we have lots of ideas. So symptoms, how do symptoms differ between men and women in Parkinson's? Probably all of you are aware of the information on this slide. So when we talk about Parkinson's symptoms, we talk about motor symptoms and non-motor symptoms. Motor symptoms are the symptoms that we can see. You come into the office and I can see these things when I look at you and when I examine you, and others can see these things. And they're the things that make it difficult to move. They're the things that respond the best to the Parkinson's medication. And then there are the non-motor symptoms, which in many people, although not in our group apparently, but in many people are really more troublesome than the non-motor medication or than the motor symptoms. They often go unrecognized because depending upon who you're seeing for a physician, they may or may not be aware of all these potential symptoms, and they may not be asked about. And a lot of them are really vague. They could be from a lot of different things. So you may not think to tell your doctor about these things because, I don't know, maybe you have pain. You didn't know that that was a potential symptom of Parkinson's. And so you didn't think to mention it to the person who is treating your Parkinson's, and they didn't ask. So non-motor symptoms would include things like cognitive changes, constipation, fatigue, hallucinations, delusions, sleep issues, including acting out of dreams, something we call REM sleep behavior disorder, loss of smell or taste, depression, anxiety, sexual issues, visual problems, and then urinary changes. So between men and women, it seems that there's an equal intensity of motor symptoms, but there seem to be some prominent differences found in non-motor symptoms. So if you look at the second line on this chart, women are more likely to have sadness, depression, anxiety, or nervousness. So they're more likely to have psychological symptoms from the Parkinson's disease. They're more likely to complain of constipation. Dementia is more common in women, and whether that be from Parkinson's disease or from some other kind of dementia, like Alzheimer's, something else, it's just a more common finding in women. And pain is complained of more by women than men in Parkinson's disease. Men, on the other hand, are more likely to have behavioral issues. RBD is the REM sleep behavior disorder, so they're more likely to act out their dreams and have things like that happening. Sexual dysfunction they complain about more often, and then orthostatic hypotension, which is a situation where you are sitting and then you stand up and your blood pressure can't keep up with the change in positioning and the change in gravity, and so you'll have a drop in your blood pressure for a period of time and you'll get lightheaded. Women, on the other hand, if we're looking at motor symptoms, while they tend to be pretty similar, women may be more likely to have tremor at the onset of their symptoms and sort of what we call more lower body and axial, meaning kind of middle of the body symptoms. So posture issues, walking trouble, gait freezing, and falls. Whereas men might have more upper body involvement and might have more stiffness. And so a lot of this, I think, the purpose of this slide is that there's just, a lot of this is not anything we know for certain. Different from study to study, the results vary significantly. And then the other thing that's different between women and men that might affect how they function with their Parkinson's disease is what we call comorbidities. So a comorbidity is a disease or a health condition that you have that's different than the condition that we're talking about. So not the Parkinson's disease, but some other health condition that that may or may not sort of impact the Parkinson's. So women are more likely to have orthopedic issues, so osteoporosis, and that has to do with our hormonal changes over life, which can result in an increased risk of hip fractures, and then different types of arthritis. For men, it tends to be more heart and lung issues that may impact the way they function with their Parkinson's. And now we're on the second poll. So I can't see the question, unfortunately, but just go ahead and type in or put in your answer, and then we'll get the results.
Dr. Durfee, it's Nancy, and it's probably because you're sharing your screen, but as you know, who provides your Parkinson's disease care? And there are a couple choices: my primary care physician, a general neurologist, a movement disorder specialist, or other. And it's amazing so far. Movement disorder specialist leading the pack.
Good.
83%. General neurologist 17%, and then other 4%.
Okay, thank you. I am really curious what the other is. I would like to know that maybe at the end of this. So we'll get more into who you receive your care from in a little bit. And we're going to move on and talk about treatments. So like I mentioned before, treatments for Parkinson's disease vary significantly from person to person, and it's because Parkinson's is such a varied disease. Again, the person sitting next to you, if you've got anybody sitting next to you with Parkinson's disease, it's going to have a very different constellation of symptoms than what you do, and they're going to require different types of treatment. So our options include medications, surgical therapies, and then things that are just kind of lifestyle modifications. So the medications, when we talk about Parkinson's, we always think about the Parkinson's medications, obviously. So things like levodopa and dopamine agonists and those groups of medications. All of those medications act to somehow increase the amount of dopamine that we have in our body, or to make our body think that we have more dopamine than we actually do. Outside of that, so those are really pretty useful for treating motor symptoms and even for treating some of the non-motor symptoms. But then there are other non-motor symptoms that just don't respond to the Parkinson's medications. So we might use other medications like antidepressants or pain medications or medications for urinary frequency or for constipation that aren't specifically Parkinson's medications, but we're just treating the symptom that exists. Always, when we prescribe a medication, we're going to think about the other health issues you have. We're going to think about the other medications that you're on to make sure we don't prescribe something that interacts. And we're going to think about your age. So as you get older, you tolerate certain medications less well. You're more likely to have side effects from some medications, or we may need to adjust the dose. And so between men and women, what's the difference? So it seems like men and women have roughly the same sort of dopaminergic medication regimens. So to me, that would suggest that from a motor standpoint, from the motor symptoms, men and women are fairly similar. However, women are more likely to be prescribed medications for their mood, such as antidepressants or benzodiazepines, which are anxiety medications. Men, interestingly, are more likely to receive medication for cognitive impairment or dementia, which, if you recall, women actually have a higher rate of cognitive impairment or dementia. So I just found that interesting. Pain treatment is similar between men and women. So despite women and men being on similar regimens of dopaminergic medications, women have more of what we call medication complications. So meaning it's not really a direct side effect. It's not like you take the medication and get nauseous. That would be a side effect, but you're taking the medication, it's working for you, but there are some issues with the way the medication is acting. So maybe you take your medication and it takes a half an hour or so to work, maybe more, maybe less, maybe sometimes it doesn't work. And then it kicks in, and maybe at the peak of the dose when it's working really well, you might get excess movements or dyskinesias. And then maybe you'll feel it wear off again and you'll take your next dose. And so these kind of fluctuations, we call them, and dyskinesias are what we call medication complications. And those seem to be more prominent in women than men. So moving on to surgical options. Anybody who comes to Albany Med at least probably knows lots about deep brain stimulation surgery. Of the two surgical options, this tends to be the go-to around the world for lots of different reasons. So what deep brain stimulation surgery is, so during the surgery, you will have leads, 1 or 2 leads placed deep in your brain through which we can send electricity. It's thought that the electricity we send through will override whatever abnormal activity is happening in the brain. So your brain and your neurons are like a big electrical circuit, and we know that they give off the wrong kind of waves, the wrong kind of wavelengths in people with Parkinson's disease. And so what we think we're doing by putting these leads in and sending electricity through is correcting those abnormal waves, though we're not totally sure about that. It's connected through a wire that goes under the skin behind your ear into a battery pack in your chest. And that battery pack serves first to provide the power, but also it remembers all of these different parameters that we can change in order to best control your particular symptoms. The Duopa pump is a pump that delivers what we call an intestinal gel of carbidopa levodopa. So for this procedure, you have a tube that goes through your abdominal wall into your small intestine. And then there's this gel, exactly the same thing you take by mouth, but in the gel form that is infused into it constantly throughout the day. So this has a couple of benefits. Number one, we know carbidopa levodopa works. So it's just taking that medication and delivering it better. Because you're getting medication kind of all throughout the day evenly, you shouldn't really have dyskinesias and fluctuations to the extent that you have without the pump. And it also bypasses at least part of the GI tract. So some of the issues that we have with medication unreliability is that it has to travel through the GI tract, and the speed of travel changes throughout the day depending on what you've been doing and what you've been eating and all that. So this kind of infuses it directly to the place that it gets absorbed. Next poll.
Okay, so this one, your last poll, does anyone here act as a caregiver for a family member or friend? And so far, it appears that that is not the case, but we're going to give it just another few seconds to learn more about the audience. So our results seem to be that overall, the majority of individuals tuning in today are not, but 70% of our viewers say yes, they are a caregiver, but it doesn't impact their Parkinson's disease. And yes, there are a much smaller number, but no less important, 4% who do say that being a caregiver is impacting their Parkinson's disease.
Okay, great, thank you. I know of at least one in the audience that is a caregiver. Okay, so women with Parkinson's disease who receive DBS are reported to have better improvement in quality of life than men. Interestingly, women are less likely to receive DBS. So why is that? I don't really know the answer to that. I mean, part of it is that women are less likely to have Parkinson's, right? But even adjusting for that, is it that women are less risk averse, or that they're afraid that having a surgery will make them a burden? Is it that doctors just have some type of bias thinking, you know, that allows them to, or that causes them to offer surgery more to men than to women? I don't know. I don't think we really know the answer to that. And then we'll move on to lifestyle modifications. So exercise, again, I already kind of gave my spiel about that. It's the one thing that we have that slows down disease progression and allows for better outcomes in people. Diet, you know, there's also sort of controversy out there about this. My general feeling about diet is you should just eat a healthy diet, and that's going to make everything feel better, regardless of whether it has any impact on the disease itself. It's generally recommended that a Mediterranean diet, which is shown over to the right, pretty much, I'm just noticing, is good for overall brain health. And then, of course, we would look for all the therapies, depending on what types of issues you're having at that time. You know, during your course of your disease, almost everybody accesses those therapies at some point. So why might treatment options differ? I kind of mentioned this. Patient preference, maybe women are just less willing to accept risk than men are, and therefore less likely to agree to a surgery. Again, maybe physicians have sort of biases that that results in them offering different treatment options to different genders, and just other health conditions and comorbidities. Okay, so you know what? I think, Nancy, now is a good time to stop. It's 1:37.
I agree.
Before I get into the next section.
Okay. Thank you so much. And the reason we're stopping is because something that's been mentioned several times already today is movement or exercise. And I'm really thrilled to have involved in today's presentation, besides Dr. Durfee, another wonderful Albany superstar. Rochelle Smith Stallman is a board certified dance movement therapist and licensed creative arts therapist.
Hello, everyone. Oh boy, this is all crazy for me because I haven't been able to hear a word because my computer is a little messed up, but hopefully you can hear me, and we're just going to have a lot of fun. So let's just start out and take a really good stretch. Oh man, you can make some noise, kick out your heels. Oh man, just stretch all over the place, as wide and long, as big as you can. Take a deep breath in, lift up. Let the air out, go all the way down, say, and just walk your hands right back up your legs. One more time, breathe in, lift up. Let it all out, say, and walk your hands all the way back up. Keep it going, touch your chest, top of your head, stretch both arms way up, way up, way up, and come all the way down really fast, all the way down. Get your legs, get your chest, say, get your cheeks, top of your head, all the way down your arms and underneath, all the way down and underneath. Wipe everything off and give yourself a really big hug. Just squeeze tight, and then take your hands and massage your arms all the way down. Rub your hands together really good. Rub your legs out. Good massage coming down, coming up. Brush everything off. Shake it out a little bit. Breathe in, lift up. Dive down to the heart. Just hiss out. Nice. So, everybody just stretch one arm up, Relax it down. We'll try the other side up.
I don't see any matching places.
Whoops.
Sorry about that.
Sorry about that. Relax that down. Both arms way up. Relax it down. Bring one hand on your belly, one hand behind. Everybody bend forward. Bravo, everybody. Give yourself a hand. Thank you so much for joining me. I teach classes on Zoom. You can join me anytime. It was great dancing with you. Bye-bye. Oh, and now we go back to Dr. Durfee.
Thank you for that, Rochelle. All right, I just have to get my presentation teed up again. Okay, hopefully everybody can see and hear me. And we're going to talk about the care of Parkinson's disease and how this may differ also between men and women. So recommended Parkinson's related healthcare services. So a neurologist, at a minimum, we would recommend a neurologist. The primary care physicians are fantastic at knowing when to refer patients to us. And then preferably a movement disorder specialist. And the reason for that is, a specialist in the disease that you have tends to just have a little bit more up-to-date information and maybe resources to help you the best that they can. All of these different therapies, the physical therapy, speech, occupational therapy, many of you have already visited these therapists, and they serve a certain role in certain situations. Social workers can be helpful, and that comes into play when we're trying to do things like navigate home health care, and when we need sort of a little bit more support at home, the social workers can help out with that. It never hurts to have a psychologist, to have somebody to talk to, and there are times that I will ask a psychiatrist to manage the medications of my patients with Parkinson's that have really kind of refractory mood issues. The pharmacists are always helpful. They're always there to remind us when we're prescribing unsafely. And then a dietitian, nurse practitioner, sometimes those can be helpful depending on the way your practice is set up that you're going to. So why is it important to see a neurologist? So, the goal of treating Parkinson's disease is to keep you as functional and as normally functioning as possible for as long as possible. And this is what we as neurologists and movement specialists do all day long. So we've got all of these different therapies on our radar, and we know exactly when it is the right time to introduce them in whatever situation. Keeping you mobile and keeping you strong and keeping you safe through the use of these therapies and appropriate medications results in better mobility, less likelihood of developing a hip fracture, which is a huge, one of the biggest, most common reasons for being admitted to a nursing facility. And therefore, you are less likely to end up in a skilled nursing facility. So women with Parkinson's disease, they live longer, right? So they are more likely to have a longer disease course. So from the onset of their symptoms, they just have longer to live and longer for their disease to progress. There's also a longer time from onset of symptoms to diagnosis, and then onset of symptoms to when they first visit a movement disorder specialist. I don't know if some of this is, as we saw before, women tend to experience more of the non-motor kind of vague symptoms. So it might be harder for a non-neurologist or a non-movement disorder specialist to recognize some of those symptoms as possibly being Parkinson's. Women are also more likely to be unhappy with the process of obtaining a diagnosis of Parkinson's disease. So who is more likely to see a neurologist? So it's the men, of course, at the top. And then the women. I'm not sure in this graph what happened to the Asian women, but I guess the point is, you know, it's all the men at the top and the women at the bottom, with the exception of Black men, which are at the very bottom. And why is this? It's not really sure. So are women accessing care? They are less likely to see a physician. They're more likely to be placed in a skilled nursing facility. They're more likely to receive home health care, so outside care from, you know, an agency or a nurse that comes in. And they're more likely to receive hospice care, which isn't necessarily a bad thing. Hospice care is actually is a great service when it's appropriate. So women, again, are more likely to reside in a nursing facility, 34% more. And once you end up in a nursing facility, if you end up in a nursing facility, most people don't, but if you do, you are much less likely to receive care from a neurologist. You know, most facilities have sort of their in-house physicians who kind of manage everything. So you may not have an actual neurologist that's managing your symptoms. And what are the leading causes of placement in a nursing facility? So I already mentioned hip fracture and dementia. So if you remember, women are much more likely to experience dementia from any cause than men are. So what barriers might prevent care in anybody? So transportation difficulties. So just for example, in our area, you know, at Albany Med, we don't have any movement disorder specialists within miles and miles of here. So if you live in way far in upstate New York, it's going to be hard to find a neurologist that isn't, or a movement disorder specialist that doesn't require hours of driving. So it might be difficult to get there. On top of that, maybe you don't drive, you don't feel safe driving that distance. So it's just hard to get there. Again, there's limited service available. Social isolation. So there are people, and again, we'll see this in another slide, but women are more likely to live alone and to be their own caregivers and to not have that social support. So it may be harder for them to access the care that they need. Limited physical mobility. So in Parkinson's, it's a disease characterized by limitations in physical mobility. So it may make it hard to get to appointments. And then financial constraints always. So this is where that caregiver question came from. So the difference in women is that they very often serve in a caregiving role for others. And that includes partners, aging parents, children, and grandchildren. So being a caregiver is sort of a condition in itself. You know, caregivers do tend to neglect their own health issues. They tend to take less good care of themselves, and they're more likely to be in poor health than those who do not serve as caregivers. And it's not unusual that women with Parkinson's disease are serving as caregivers for other people, so they don't really get the opportunity to focus on themselves and their own disease. Another aspect of difficulty in caring for women with Parkinson's is that the second bullet, they're more likely to come to office visits alone. And so anybody that knows me as a physician, I welcome the extra information that comes with being accompanied to an office visit. I often get a different story from the spouse or the friend or the child than what I'm getting from the patient. Sometimes it's a more objective view, and it's nice to have two sets of ears, you know, when we're talking about complicated things and we're talking about medication changes and things like that. And so men are almost always accompanied by somebody, and women are much less likely to be. They're also more likely to live alone, and they're more likely to be in a situation where they're paying non-relatives for care rather than having a family member care for them. And once again, despite poor health outcomes, women with Parkinson's are living longer than men, which makes it really important to focus on the quality of life and of maintenance and sort of functional maintenance over the course of the disease. So in conclusion, women have a lower risk of developing Parkinson's. They're more likely to report certain symptoms, particularly non-motor symptoms like pain. They're more likely to experience medication complications, including motor fluctuations and dyskinesias. They're less likely to get DBS, to be cared for by a Parkinson specialist, and less likely even just at all to access medical care for their Parkinson's. So the Parkinson's Foundation has lots of information on its website, and I actually went and downloaded this report, and it's good, interesting reading. There are a lot of really interesting quotes in there from women with Parkinson's disease about what it's like to have Parkinson's disease as a woman. It's worth a read, or at least a breeze through. And then I don't know, Nancy, if you wanted to talk about these last few slides.
Yeah, okay. So what's represented there and is really important and core to us, these are what we refer to as our 3 pillars. And research, care, education, that's how we manage to devote the work and the energy that we need to do. And when this project started, this was a special project grant funded several years ago, and it has really evolved over time because the need and the attention is still required to highlight the gender differences between women and men. That will include the Parkinson's Foundation continuing to advocate for more inclusiveness of women in research. The care issues that Dr. Durfee has already mentioned, we know are significantly different for women, and that's part of our advocacy agenda. And what we're doing today, letting people know more and more about why these differences are what they are, at least through our education and empowerment. So that's a big part, and it all ties back to that report that Dr. Durfee just mentioned, and that you can read on our website, and encourage you to do that. I know I've been referring you to our website a lot, but our website is a huge font of information. So another slide that you wanted me to?
This is all Parkinson's Foundation stuff.
Okay.
Yeah.
So I think we covered that, and I'm sure everyone would be really interested to read all the citations that come after this.
There they are.
What you need to know is that this was well researched, so there's a lot of science behind all of this. So that's probably a good way for us to transition to our Q&A session. And thank you so much for the questions that you have submitted already, and please continue to do that. We have some time. And before we move totally to the Q&A, I want to say once again, thank you, Rochelle. That was just marvelous. And I meant to mention that it might be a little tough to have seen, but you have a brand new Dance Beyond Parkinson shirt on today. So thank you for being part of this. We really appreciate that. And for all the folks who have tuned in from not only the Albany area, which many folks have let us know that you're tuning in from there, but also Canada, Connecticut, and of course, other areas of New York State. So thank you all very, very much. So let's take, Dr. Durfee, ready for the first question?
I'm ready.
Okay. So one of the participants today is asking, is there a maximum dose of Cinemet to be taken each day?
Yeah, so everybody has kind of their own maximum. The way that we determine a maximum in somebody is when they no longer tolerate the amount that we're giving them. So, and not tolerating it would be, you know, maybe you have really wild dyskinesias and you just can't take anymore, or maybe that particular dose is making you really lightheaded and we need to do something about that before you can take any more, or you're confused and hallucinating on the dose we're giving you, and that dose is going to be different from person to person.
Okay. So it sounds like something that, in talking very closely with your doctors and your care providers, yes, is really an important step. A few moments ago, you were talking about the access to movement disorder specialists, and another question here, and it's somewhat COVID related too, is Albany Med, are you doing telehealth visits?
We are, you know, back in March and April and May, we were almost exclusively telemedicine. For the most part now we're doing in person, but But I still have a patient or two a day that just prefers phone or video, and that's fine. And we do it that way.
So that's great. You really are able to customize the delivery of
Yes.
care. Wonderful.
Yeah.
I wonder, people are wondering about clinical trials and research. Would you like to address, like, where can people find out about the opportunities to get involved in clinical trials?
Yeah, so one way to find out opportunities would be just at your movement disorders clinic, wherever it is that you go. And when we see patients, we have a handful of studies that we're participating in right now. And if we come across a patient who we think would be a good candidate for a study, we'll often bring it up. And then, clinicaltrials.gov. So, yes, thank you for putting that on, Danielle. Yep. So she put down a couple of websites where you can go and search for clinical trials that are specific to what you're looking for.
Absolutely. And I'm going to mention this a couple times before we end. Any questions that we don't get to, any questions that you think of afterwards, call our helpline, 1-800-4PD-INFO, and you'll have access to that number as well. So the next question came in, and it's actually two, so I'm going to break it up. So what are your thoughts about this, Dr. Durfy? Do women with Parkinson's take better care of themselves and manage their symptoms better than men who have Parkinson's?
So I would say, I think it is very dependent on the situation. I do think the women that are the ones that decide to take very good care of themselves, and they are not pulled in too many different directions, caring for others, doing things like that. I do find that there is a group of people that really embraces it and really does a great job of trying to keep themselves healthy in all ways. But then again, as mentioned, women are more likely to be caregivers and more likely to put others first, and more likely to worry less about their issues and more about the issues of the people around them. So there is certainly that group of women also who falls into that category.
You did address this already, but I just want to make sure, particularly for the person who asked this, that we just reiterate. The person who asked the first question there said, do women with Parkinson's live longer than men with Parkinson's?
They do. Just women in general live longer, regardless of what the health issues are. So yeah.
Okay. The next one has, our next question really has to do with some really concrete things that would be, of course, a question that anyone with Parkinson's might ask. Wondering if there's any kind of help available at no cost or low cost. This individual who's asked this question is wondering because they are having some trouble dressing, doing their chores, what commonly referred to as activities of daily living.
This is so difficult. If there, insurance, depending upon your insurance, there usually is some coverage of what we would call a home health aide, somebody that would just come in and help with those basic things. There's usually limited coverage, so you might get, a certain number of hours per week, which then for the remainder of the week, you don't have anybody there to help you. Resources are short. So I would say, one, there are often, what do I want to call it? Like senior organizations that are run by towns that would be useful to contact, to see if, and this will be town and area dependent, to see if they have any resources available, rides and those other kinds of things, just companions, stuff like that. So and Nancy just put something in anyway. Is that similar to what I'm talking about?
It is, and unfortunately, I just sent it to our panelists. So I'm going to send it out again and explain a little bit more for anyone who's tuned in and who is a New York State resident. You should be aware and know that every county has something called New York Connects, and it varies greatly from county to county. But I would strongly encourage you, and I'm going to give you the number here in just a minute and get it out to everybody. New York Connects is essentially the line that you would call for your long-term care needs. They are going to be a place of information and referral. Get connected with New York Connects. That will be of great assistance to you. So here comes the number, and you can always call me again if you lose it. Okay, that's New York Connects.
I'm going to write this down too.
Okay.
I don't have this number.
Okay, so let me get back to my questions here.
Yep.
All right, so I'll give Dr. Durfee a chance to be writing down
That's
that
good.
number.
I got it.
Okay, and the next question, I'm going to interpret a little bit here. The person is asking, how soon does the other side of the body start to have symptoms? It sounds like perhaps symptoms first appeared perhaps on one side.
Yeah.
Can you address that?
Yeah, and it's kind of the same answer, you know, it really varies. Gosh, I have people that have had Parkinson's, rarely, but I have maybe one or two people I can think of that have had Parkinson's for many, many years and have hardly anything on the other side. Most people, I would say, at the time that they're diagnosed, they do have symptoms on both sides, although they might not recognize the symptoms on the non-dominant side.
Okay. Once again, like Parkinson's, everybody is so unique.
Yes.
Talk to your care team. Restless legs, unique to Parkinson's?
So restless legs is interesting. It is associated with lots of different things. People with Parkinson's disease are at an increased risk of experiencing restless legs, but restless legs is also something that, you know, you might develop in your teenage years. Yours truly developed it in her teenage years.
Oh, wow.
And it might be something that, you know, if you have kidney failure or anemia or other health issues as you age, it might develop then. But Parkinson's disease is one of those conditions in which you have a higher risk of developing it.
I personally can say I've heard a number of people mention that. So
yeah,
how bothersome that is. How about marijuana, cannabis, and PD? That is a topic that comes up a lot. I know we have information on our website, but what can you tell us about what the research says about marijuana and PD?
So for those who live in New York State, you'll know that it's what we call approved for Parkinson's disease, but I just want to clarify that that was approved through political means, not based on sort of any scientific evidence. So the evidence is pretty shaky that it does anything. I rely more on my personal experience versus what any of the research shows. And I'll tell you that I have, you know, there are very specific situations in which I found it to be helpful. I have some people that have very bad dystonia, so cramping of their feet or their hands, and it's episodic. They have short episodes of this, maybe, I don't know, maybe it occurs a certain time of day or something like that. And I have had a handful of people tell me that medical marijuana has helped, or CBD even has helped with that, though it's very short acting. So if it's sort of a problem that you have 24/7, it's probably not going to do it for you. I do have a couple people that use it for sleep, and you know, that's the only thing that works for them to get to sleep, and we need to sleep, so that's fine. It's not really beneficial for tremor. I mean, it might be beneficial in the sense that tremor tends to get worse with anxiety, and you know, marijuana in a lot of people, not everybody, but in a lot of people reduces anxiety, and some people it makes it worse. So I mean, it might sort of mentally settle down your symptoms a bit, but it's certainly not it doesn't change disease course. It's definitely not for everyone. And I really only recommend it in very specific situations.
Interesting. This question came when it did, because it's a great segue into the next two questions.
Okay.
The next one being about sleep and REM sleep disorder. And
Yeah.
this person writes in that her partner tells her all the time, you know, you have a lot of bad dreams, you're reaching out, you're punching in the air. What's going on, and what can help this?
Okay, so what's going on? So Parkinson's disease is characterized by an abnormal protein called alpha-synuclein, or abnormal alpha-synuclein protein. It starts in your gut years and years before you're diagnosed. It makes its way into your nasal valves, which is why many people lose their sense of smell, again, years before they developed other symptoms. and then travels up through your brainstem before it gets to the part of your brain that causes the motor symptoms. Within your brainstem is a little area that I can't remember the name of, that when you're dreaming at night, that little area is responsible for collecting that signal from your cortex, which is the part of your brain that tells you to move, and stopping it so that when you dream, you don't act out your dreams. In Parkinson's disease, that same pathology that we see everywhere else is also seen in that area. So that sort of blocker, or that area of your brain that blocks the signal coming from your cortex when you're dreaming, is not functioning. And so you start just acting out whatever's happening in your head. And what can you do about it? So it's interesting the way the question is worded, because it usually doesn't bother the person who's dreaming very much, unless they're, unless they're falling out of bed or bruising themselves. It's usually the partner who's bothered. And so if it's not too big of an issue, I don't often do anything about it. But when it does become an issue, I always start with melatonin, which is just an over-the-counter supplement. Melatonin is a hormone our body makes to signal that it's starting to be time to go to sleep. And sometimes you can take a little extra melatonin, and that helps. And then there are some prescribable medications. Also sometimes reducing sort of late in the day Parkinson's medications if it's possible. So if you're taking levodopa at bedtime and you don't really need it at bedtime, you could stop it, and after talking to your doctor, obviously, and that might improve the dream. So it depends, but there are some options to improve it.
Okay. All right. And once again, related to the marijuana question and how you related it in a way to this, depression in women is a very familiar topic in general. What should women with PD be aware of regarding depression, and how do women get help?
Yeah. Well, I'm going to tell you that I know that 3 of the people that are on this talk here are patients of mine, and they are very good friends, and I like to use them as an example. They all have, obviously they all have Parkinson's disease, because everybody here does. And they have found this really amazing group of really supportive women, and they are just the happiest. I mean, I just, it's something that I really love to see. So, and I see that, I'm just thinking about them because they happen to be here, but it's true. I find that, especially for women, if you find ways to connect to other women through support groups, or in any way at all that, that sort of understands what you're going through, I find that to be one way to really deal with the depression. Obviously you should talk to your doctor about it. Oh geez, sorry, my computer just shut off. There we go. Okay. You should talk to your doctor about it. We'll certainly prescribe medications when it's appropriate. Support groups aren't for everyone, but if they're for you, that can be a great way to sort of have less anxiety and less depression about your diagnosis. Exercise, I'm a big proponent of that for lifting up moods. And this particular year has been so hard on all of my patients' moods, and especially the ones who exercise, because they're not getting the socialization of exercising, and they don't get to leave the house to go to the gym, and they don't get the endorphins, and they're doing their best at home, but it's just not the same,
Absolutely. So challenging right now.
Yeah.
Once again, you just created a great segue. Of course, naturally, people with Parkinson's are wondering about COVID, and if we want to prevent anyone from getting it. Any particular recommendations, suggestions you have regarding Parkinson's and COVID?
Yeah, so the Movement Disorder Society actually just, I think last week, put out a statement about sort of COVID and Parkinson's disease and vaccination and Parkinson's disease. And essentially the bottom line at the end of it all is that to do the same things that everybody is recommended to do. Parkinson's doesn't necessarily put you at an increased risk of issues, although I would argue that if you're less mobile and things like that, that could put you at an increased risk if you do develop COVID. But you should get vaccinated the way the rest of the population is trying to get vaccinated. And based on your age, things like that. Parkinson's disease is not one of those diseases that they're considering to be sort of one of the riskier ones in terms of this.
Okay. And there is more information on our website from our medical director as well. Recently, he did a whole Facebook Live, which is recorded. You can access it about the vaccine. I know a lot of people are very interested, have naturally good questions about it. So someone else is asking about their pain experience, and she experiences pain before her next dose of Cinemet. Can you comment about pain and PD?
Yeah, pain and PD is tough because it's so big, and it's one of those things where people come to me and tell me they have pain and ask me if it's from their PD, and I say I really don't know if it is, you know, and we kind of make sure that it's not from something else, and then decide, well, maybe it is. You know, the pain in PD, most typically, but not always, centers on the muscles. It's often worse on the side on which you're most affected. So if your left side is the side with the bad tremor or the bad stiffness, it's most often going to be on your left side. It's not unusual for it to involve the shoulder area. And you're lucky, whoever asked the question, that it responds to levodopa, because that opens up a lot more treatment options. There are some types of pain that just don't seem to. You know, there are people that have what we would call visceral pain, like pain in the abdomen, or, you know, in this area that just, it's really hard to treat. It just doesn't respond to much of anything. But you know, for somebody, and again, I don't know who was it asked, and I don't think I'm your doctor, but what I would do, you know, in that situation was try to get you better coverage during the day with your Parkinson's medication. So I would mention that to your doctor if you haven't, and there might be ways to reduce that time where your medications are wearing off.
Wonderful, thank you. Another really difficult symptom of Parkinson's is constipation. And another woman is writing that for her, it's so painful and disrupts her life, and at times can be very embarrassing. Any suggestions of how she can get some relief?
Yeah, you know, I wish that we train people to be movement. So we have what we call fellows that we train to be movement disorder specialists. And one of our fellows this year has a concoction that a recipe that he gives out to people. And I wish I had it handy to tell you, but there are things like that out there. He calls it like the bomb or something. I can't remember, but there are certain recipes out there that can act that way. But obviously, if you know, it's in Parkinson's disease, constipation often is worse than what, you know, increasing fluids and increasing fiber can really fix. So I always tell people to start with a stool softener, which you can buy over the counter, and take that daily. That doesn't often solve the issue. People with Parkinson's often just have to take laxatives. And I mean, we don't encourage the use of laxatives in most situations, but if nothing else is working and that's what you've got, it's better than being sent to the ER in pain, you know, not having gone for a week, because that's a whole nother situation. And then when it's that refractory, I'll usually send people to GI. There are a couple of new medications that they can use that I don't prescribe, but that might be able to help.
So in essence, kind of expanding the care team as part of addressing the Parkinson's symptoms. Okay.
Right.
Another woman is talking about in her question how to explain to her family and friends that she's not being lazy or that she is apathetic and she doesn't want to exercise all the way, but she gets tired. I think she's talking about fatigue. How can we help support someone in that situation where maybe they're being
so I guess I would ask if she brings her family members to appointments. Because a lot of the times, if you get the explanation from the doctor or from somebody else, it's a lot easier to accept. So I would encourage you, and maybe that hasn't worked, I don't know, but I would encourage, you know, you all to bring a family member or a friend to your visits when you can. A lot of places are restricting people, but we always let somebody come in because it is useful to have multiple ears, and in situations like that, I'll just tell the family member, you know, it's the disease.
Right. Okay. All right. Someone else is asking about genetics, and you mentioned this during the presentation. This is very specific. This individual was diagnosed 2 years ago. Her father also had Parkinson's, and they suspect that maybe her grandfather had it as well, but it was
Yeah.
never confirmed. It seems like Parkinson's is hereditary, and certainly can understand why she would think that. Should she be worried about her children?
Yeah, so what it's, and again, not knowing you or your family history in detail, I don't want to, I don't know this for certain, but what it sounds to me is that you have this, I don't know if my explanation of dominant versus recessive was helpful at all, but it sounds like in your family, this would be a dominant gene, meaning you only need to inherit one copy. And it sounds like you've inherited that copy. You got that copy from your dad. Your dad got that copy maybe from his dad. And you probably have one copy of the Parkinson's gene and one normal copy. So that would mean each of your children are going to get one of your two copies, and it might be the Parkinson's copy, it might be the non-Parkinson's copy, but that means that each of your children, if it's true what I'm saying, has a 50% risk of having that gene.
This, and Dr. Durfee, you can certainly correct me because you're the medical expert here. It just, it seems like perhaps this might be a great opportunity to take advantage of our PD generation work with
Definitely.
the genetic testing, and that comes with the genetic counseling. So it's very different from other places that are doing genetic testing. So once again, parkinson.org/PDgene. Please visit there, check it out. And once again, because of COVID, it has all moved to in-home in addition to site-based research studies.
Yeah.
Our last question today, can't believe our time is flying by here, but this will be our last. What are your thoughts on waiting to take levodopa? This person has had Parkinson's for 12 years and doesn't take levodopa, takes Mirapex.
So again, it's going to vary from person to person what my recommendations would be. It used to be thought that we should, quote, save levodopa, that we should use other medications and save levodopa for when your disease is worse. And some of that stems from also old information that has since been disproven that levodopa only works for a certain period of time. And we know that that's just not true. So levodopa will work forever if it works for you. Your disease will continue to change and it will make it harder to treat with levodopa, but the levodopa is going to continue to work. So the thinking in the movement disorders world has changed over the past, 7 or 8 years, and that we now most often use levodopa as our first medication. And some of the reasons for that is outcomes. People just seem to do better when they're placed on in the long run, when they're placed on levodopa earlier in the disease. For what reason, I don't know. And, one of my thoughts is maybe levodopa is by far the medication that works the best. It's the one with the fewest side effects. The medications like Mirapex come with pretty funny side effects, and they all have their place, but they can, they can cause kind of funny things. So levodopa is really the cleanest one. It's the most direct one. And it's the one that tends to work the best. And I want my patients to be functioning as normally as they can possibly function for as long as they can, because it's going to allow them to exercise and to be socially active and all the things that are really important in neurodegenerative diseases.
So well said, and so aligned with the Parkinson's Foundation about helping people to live their best life.
Yeah.
Many, many thanks, Dr. Durfee. This has been spectacular. So much information. Thank you for responding to all these questions. Thank you, Rochelle, for giving us a great movement break. And many thanks to all of you who have logged in and tuned in today. I really so thankful that you joined us. And I want to thank our program sponsors once again, AbbVie, Acadia, and Medtronic. Thank you so much for your generous support. Today's session has been recorded and will be archived on the Parkinson's Foundation YouTube channel within a few days. You'll get a link directly to your email with information about how, if you'd like to see it again or check out some of the questions. I also wanted to share with you how to stay connected to us and stay connected to the Parkinson's Foundation New York, New Jersey chapter. And I didn't put on this slide, but I'll tell you too, in case you're tuning in from somewhere else. You can find out, if you're in the United States, what chapter you come under by visiting parkinson.org/chapters. For those of you in New York, Feel free to write directly to us at the chapter email box. So you can write directly to me. Visit our chapter page. You'll find information about upcoming programs. You'll find information about support groups, wellness programs. And I hope you will like and follow us on Facebook as well. And lastly, please stay connected to us nationally. Use our helpline. They're there waiting for your call. The website, I'm not sure how many times I've cited it and recommended it today, probably too numerous to count, but you will find so much information on the website that can be easily accessed. So with that, I will say thank you again. I hope that you all stay very safe, stay warm, and I hope we'll see you again soon at one of our next programs. Thank you again, everyone.